Hello, everybody. Welcome to episode 5 of Interoperability Unlocked. Today's episode is called Crossing the P's. We are going to dive into the critical connections between providers, patients, and payers. If you haven't joined us before, I'm Courtney Baker, the marketing manager at CommonWell, and I'm always joined by Liz Lewis, our director of product. But today we have a familiar face to join us. You may or may not know him. We have Paul, our executive director, joining us today. Paul, do you want to give a quick intro?
Hello, everyone. So I work with these lovely people who do all the hard work, and I just try monitoring. I don't say take credit. I think I give credit. I try, but thrilled to be here. I've been watching all the episodes, and I was wondering when I was going to get invited.
It didn't take too long. We're only at episode 5, so
made it to the big time. Very excited.
There you go.
Awesome. Yeah. Okay, so today, like I said, we're going to discuss those 3 Ps. Let's kind of start with the basics. So why are we focusing on these 3 Ps for today's discussion? And Paul, let's start with you.
Simply we want to add more Ps, and there aren't 3. There are we keep finding ways to make things that aren't Ps become Ps, and that's kind of become like a wordsmithing game over here. Well, welcome to marketing 102. Figure out how to make things fit. So many moons ago, we were talking about really provider to patient, right? That these 2 Ps are directly interlinked, right? You don't have providers if you don't have patients, and we were having great success in the movement of data from provider to provider, that P1. And then when we tried moving data, saying, hey, we got all these tracks laid, let's see if we can get patients their data. And we tried moving from provider to patient, it got hard, right? Mm-hmm. And it wasn't 100% clear what barriers we were going to experience. And now we're in the process, from our own efforts, started, what did we start, about 2019, really, to get movement to payers. And then Tefka talking about it as well, and it's kind of a topic in general. So we've added a P into the focus: provider, payer, patient, and then I have a whole litany of other Ps I can add if we really want to get there.
Yeah. So Liz, I'm going to jump over to you. And this may seem obvious, obviously, to us and people within this industry, but why does interoperability matter for each of these different Ps, so to speak?
Well, I mean, to Paul's point, we've been doing the provider to provider thing since day one.
Yeah. And,
even pre-CommonWell, a lot of the interfaces, at least a lot of the interfaces in my world and probably a lot in Paul's world, were still provider to provider. And so over the decade plus 2 decades of this exchange, like that just became the norm.
Mm-hmm.
We've always believed in patients having the right to access their own data. It's something that they are guaranteed under HIPAA, an individual right to their data. It's their data. I hear not a lot, but I sometimes hear that it's the provider's data, but it's really the patient's data.
Yeah.
My medical information about me is mine. The provider is a steward of that data, and they have regulations and requirements around that stewardship, but it's really my data. So patients shouldn't have to jump through hoops, and they certainly shouldn't have to pay to get access to what is theirs.
Or it should be a really, really, really big hoop and only one of them, right?
Yeah,
right.
Or just right through that hoop, thing. And it's right. And that's not the case. We have information blocking rules that have come out. I don't know if they have real teeth. I've sort of yet to see if they have teeth, at least, in the seat that I'm in, but we're still advocating for patients to be able to get access to their data. And then payers, again, not, contractually payers have a right to this data. If I'm a payer and you're a member of my health plan, you may or may not know this, but when you signed up for my health plan that I'm offering to you, you're giving me the ability to access your data. And so that's already happening. That already happens. It just sometimes happens in a more difficult, old school way. And it doesn't make sense from a cost savings perspective to continue to have people knocking on doors, fax machines, we have people traveling around with fax machines in the back of their cars. It's 2025. Like, what are we doing? So, I mean,
what's a fax machine?
Right?
I don't know. If you asked me to use a fax machine right now, like I could figure it out. I've used a fax machine before.
Yeah.
It's been over 10 years since I personally myself.
Here you like plug them into like a thing called a telephone line.
When I did credentialing like 15 years ago, we had to fax a lot of the verification requests to hospitals. A lot.
Still happens.
Yeah. It's crazy.
I think I have a printer upstairs that theoretically can operate as a fax machine. I don't have a phone line to plug it into.
Right. Yeah. Crazy. Okay. Paul, so we're going to keep expanding interop between these 3 Ps. Obviously, that's the goal. How is that going to help deliver better outcomes, and who for?
It's a great question. So first of all, to Liz's point about who owns the data, we can get in that debate for a long time because there's actually a contract law definition of that and a colloquial definition of that. But when we think about healthcare, a lot of things happen in an obtuse or opaque, or pick a word that indicates, I don't know what the heck is going on here, method. And a lot of it has to do with intermediation, sure, but a lot of it also has to do with there are checks and balances that exist. We don't necessarily want people that are repeat users of the same healthcare service to keep using it over and over. One, and unnecessarily, and two, potentially against their own safety. And we have some clinical checks in this. Let's take radiology as an example. There's you're supposed to record the amount of radiation you receive from clinical exposure procedures so that you don't accumulate too much of it. Like, you're going to accumulate it anyway. Like, I'm not sure if you know this, you get on a plane, the average plane flight, you're exposed to as much radiation as a chest x-ray. Oh, that's interesting to know. There's a lot of pilots out there doing a lot of chest x-rays. Now, it happens to be a very long exposure or very small amounts of radiation, so it tends to repair itself and no body damage by the time you land. But overall, when you think about chest x-rays and CTs, those are quick hits of a lot of stuff, and that has a different body effect than long-term exposure. We need to know the accumulation of all that stuff. Okay, so we don't want you having a CT every day, right? Like instead of looking for a full body scan to find potential cancer, we're going to cause cancer. That's a bad idea. Now, when you think on the finance side, getting my cholesterol checked every day might be interesting to see if I'm doing better or worse, and me be able to every day say, oh, I can see a difference when I had 3 days of large cheese and egg consumption versus days where I don't, right? Maybe I can get an insight, but that would be an excessive amount of lab results to be paying for someone to track at that fine at a level. You check this every 3 months. So there's checks and balances of, I'm not going to allow you to do that procedure because you just did it. And sometimes it's a mistake. I went to a new primary care doc. My last one didn't know that they didn't know I just did this last month. And the payers that are kind of help say, I don't think you need to do this again. We shouldn't really pay for that. Right. Don't have that procedure right now.
Right.
That requires data, right? It requires the payer to know what's going on and vice versa. So but now you fast forward a little bit to the patient experience. Like, they're trying to control costs, they're trying to increase quality, improve outcomes, all that stuff is great. In the middle, I get a phone call from my provider saying, you can't come here today because the exam won't get paid for. And I go, I have insurance. What do you mean it won't get paid for? Like, well, you just went to, I forgot about that. That was a wellness visit. Sometimes you don't know how it's coded, an office visit, a wellness visit. And the more that data takes time to get from point A to point B, the more abrasion to the patient, the less they can get the care they actually need, and everybody gets mad at everybody, right? Mm-hmm. And let's try and make happy well people versus mad not happy people that need to have medications to make them happy again.
Yeah, absolutely. So I think we can point to like the payers and working with the providers and helping to limit redundant testing as being kind of a successful connection that's already happening. But are there others right now?
A slight correction to that.
Yeah.
That's not the actual reducing extra testing is great. Okay, fine. That's a good. Let's bend the quality cost curve. There's no better quality from getting a cholesterol checked every day versus once a year if it's normal, maybe every 3 months. I don't know what the clinical efficacy of doing it more often, but I know I want to get my check more because I just got a bad number and I want to see faster results as to whether things I'm doing are improving it, exercise, change in diet, whatever. Okay, fine. But really it's about the coordination time, right? A lot of think about patient portals. Yeah, we want to get data to patients. That's wonderful. The primary use of them tends to be administrative. Right, I have an appointment. When is it? What's the address? What's the phone number I call to ask questions? I have a question about my appointment or follow-up care. It's interacting with the practice out of band of being there in the four walls of the practice. I want a medication refill. My primary care doc just signs off every time on my blood pressure medication because I need it, right? And they're very happy that I'm asking for it every 3 months because that means I'm probably taking it. I'm a compliant thing. So all that stuff needs data. And it's not about reducing the care. It's making sure you get the best care you need faster and safer, right? It's clear the gunk out of the way so that you can get the care you need and not have to sit there and wait for someone to give you the clearance.
So Liz, what does the future look like in, say, 5 years as a result of these successful connections between all of these different folks?
Well, we have been talking about this at CommonWell for 5 years. So I want to be cautiously optimistic, maybe a realist. Ideally, we have more, connected payers. I think there's two things. I don't want to lump these answers into one answer. I think on the patient side, I think there is a very big appetite. There are consumer applications circling out there, trying to figure out when it's best to jump in, looking at TEFCA requirements and trying to interpret those and see if I join, will my patients using my app really actually get data or, pull the curtain back a little bit and see what the reality is there. So there's certainly already an appetite and a pathway on, I think, that makes sense for consumer applications. And I think we'll continue to see that grow. We've talked internally about how can we accelerate that? How can we assist? On the payer side, the trust, I think, is still a big challenge. And so ideally, we don't have, not ideally, I think realistically, we may not see full blown, everyone trusts everyone in 5 years. I don't think that's really likely. But ideally, we begin to see that abrasion that Paul is talking about decrease as organizations that have, high exchange outside of CommonWell or a network like CommonWell come inside and utilize these pipes to move the data faster and more efficiently and to be able to do better things with the data. I mean, ultimately, we've talked about AI on here before. If you're going to do any sort of data analysis to then spit back out and say to the provider or to the patient, like, maybe you don't need this test again, or maybe here is a gap that I caught that you didn't. You need a robust amount of data. You don't need a piecemeal amount of data, right? So you need to have a more open exchange to be able to collect all of the necessary data, do the analysis on it, and be able to spit back out and say, yeah, here, this is what I think you should do to reduce that. Because otherwise it's like, oh, I only got 50% of the patient's data. I'm going to make a recommendation based on that, but I don't have the whole story. So I don't have a crystal ball. I don't know, Paul, what you think. 5 years, 3 years, 1 year,
Well, I think first of all, not to critique too much, but I do think sometimes the trust issue is a little bit overblown. We say that, and then in a second sentence you can say, but when I look individually at an individual practice and their payer cohort, and whether they would exchange data with them relatively freely if they could, the answer tends to turn out they would, right? Because the benefit of faster exchange is one, faster payment for them, right? And they are businesses, your practices are businesses, and having things in arrears and not being done. Getting approvals to do expensive things is really important, right? It becomes a scheduling whipsaw of, I would use this room for this high value service, and I'm holding it because I'm hopeful I'm going to get an approval over here. In the meantime, should I use it or not, right? Should I fill it with other things while I'm waiting? And so you create this waiting game on both sides, and then a revenue blockade as well. So they're like, look, I'm willing to trust, especially this stuff moves faster, right? That's great. And I don't think they're as distrusting as we think. And now there have been mistakes, right? If you look in the last year, you mentioned AI, so I'm going to jump on it. There were a couple payers that had some AIs let loose on data and do some really stupid things, right? To do, denial rates that went through the roof, because if you tune it towards the business of what a payer is looking for, denials are great. But that's not good for healthcare, right? There's deny the things that are unnecessary, but approve the things that are.
Right.
And sometimes that's a longer term view than the single episode of care. Like I look at, both, I'll reveal my own PHI, but a little bit of Liz at the same time. We're both on a very expensive medication, the same one being Dupixent. There are many models that say this should not be approved, but if you look at the downstream effects, I get two benefits from it. One, I've not been in the hospital again for a massive pulmonary event where I nearly died. Okay, that's great. I also have a large reduction in nasal polyp issues, and I was on course for a second surgery for that. And now you're looking at $10,000-$30,000 event every X number of years gone, right? So yes, expensive, and maybe I'm a high utilizer from how much they're getting in premiums. But this is insurance. Some people are going to cost more in the premium, and some people are going to cost less. It's not always about keeping everybody below, because when you keep everybody low, then you just keep dropping the premiums. And guess what? When you make the premiums go down, the insurance companies actually make less money. It's more about a steady state return of keeping everybody healthier. So we want to keep that in play. I think the major thing I'm seeing is trust that the networks have enough scale and the right data that the payers find it a good, I think there's a data quality trust issue right now, and a chicken or the egg of, is the data there? They're willing to give you the data if you're willing to show up. I don't know if I should show up because I don't know if the data is clean enough to make it worth my while. When is the point where we just try anyway? Just do it and see what happens.
I think we're close to that point. I think we are. I think we're starting to see more willing to come to the table and say, all right, I'm going to go ahead and dip my toe in, and I'll be the chicken if you'll be the egg type of thing. But I do think
it's like riding a bike. Like at some point, Dad lets go of the bike and you just start riding it, right? You're never going to convince the child. I'm not saying that's not true. There's some kids that are nuts and will just get on a bike and start going, even though they know their dad's going to let go. But most of us lie. Most of us, jog behind them, holding it. And
I'm holding you.
And they just let go, and they're down the block, and then they fall over the second they realize you're not holding it anymore, right?
But I do think so. I think you're absolutely right when it comes to trust, and when you break it down to the individual level, I do think it's there. I think the nuance that I really wanted to call out is making, in today's ecosystem, it's, if you're at the table and you have this patient, then you have rights to query for that patient. That's oversimplified. But when we have other players, and specifically intermediaries, I think when there's a payer that's like, yeah, I'm Blue Cross Blue Shield of Michigan, here I am, I'll exchange with these providers in Michigan. Great, easy, checkbox. When it's some intermediary, especially more in the startup space, it's like, okay, do they really understand what is in or out, what is good or bad? And those are the players that I think that people worry about. And to some degree, they should, protect what they are obligated to protect. And we have to sort of clear a pathway to say, here you can exchange with the ones that you know and love and trust. Well, maybe not love, that's a stretch, but know and trust. And, maybe these have to earn your trust in order for you to open up this highway for the data to move.
Yeah, I think that's very well stated. I think there's also, interestingly enough, I think a lot of those startups, not a lot, but enough of those startups are there to help with the other trust issue. They're there to help clean the data. Say, you give me raw, I'll help get it formatted in a format the payer can work with. And what the startups are doing are competing against some of the more veteran participants in that. And I won't name those companies, but they're out there. There's now the payment operations release information business, getting data from a provider to a payer, which is often for risk adjustment and other things, has like a factor growth that happened the last couple of years. It was like, a sub $100 million business to $1 billion business very, very quickly. Yeah. So you're going to see entrants come in. And what they're doing is trying to do it better, faster, cheaper, right? So that's how they compete with the existing entrenched vendors. And but what they're doing for the payers, I can do it cheaper and give you data you can trust to be what you need to do what you got to do. What's interesting is how many payers don't have a great in-house capability of this, right? They are still using some intermediary because they don't quite have the expertise on dealing with a clinical blob of data into their own. Some are doing both. A lot are doing both. They're using intermediary for now and building up people on the side. And it's not sure when they'll become direct participants versus going through intermediation.
Yep. Absolutely.
Intermediaries. You don't go through intermediation. That's not intermediation is a thing that happens, not a thing. Anyway, sorry.
No, you're good. Back at the beginning, Paul, you said you had several P's that you could likely add in. Give me another one that you would add into the existing 3, and why would you choose that one?
Do I get to list some and explain why I picked the first ones you do?
Sure. Let's do that.
There's a couple. Well, first of all, there's one going on right now that is actually also a provider. Actually, there's 2 that are a P that are also a provider. That would be a pharmacy, thinking on the place where you pick up meds, right? There's the other pharma, which we think of the people that manufacture the meds, and put them aside for a second. That's like a research use case, which I think we need to work on too. But right now we have pharmacies, and I think, pharmacists are supposed to help with contraindications to drugs, all the things they do, but they don't have the data. They're relying on I'm not sure if you've ever picked up a medication, but how do they do that? But they have a little thing on the screen that says, do you have any questions? If you don't, please sign here and we'll let you go off your medication. Have a great day. I think they'd actually prefer to add more value than that if they could easily.
Yeah.
And also we have, we're adding labs, and for that we'll use pathology as their P, and they're also a provider. So they fit in the P. If you're going past the current Ps to a whole separate category, then you see public health as probably the next best target, right? And that's a thing explicitly mentioned in TEFCA. I don't think the provider community has resistance to public health doing their job better. It's more of a matter of will and a recognition that public health has a strong, important, component of healthcare in general. And, geopolitical things are kind of messing that up a little bit right now. But I think the provider side would have instantaneous trust of a significant part of the things that are public health. What is interesting, though, that I think goes along with the trust and all the questions is when you do get at network scale, proving that something actually is a public health entity is an interesting question. You know it if you know it. Like my provider, down the street knows the public health department for the city of Hoboken, and they might know the Hudson County one. They might have heard something from the state. They don't necessarily know what to do when they get a request for a chart chase data from a Department of Health in California, whether they're allowed to respond to it or not. And that's an interesting trust question, because public health has kind of unfettered access if they want it, if they're justified as that the minimal necessary to do our job is everything about this patient. They have the right to it, but it's not 100% clear what happens on a federal national scale.
Yeah, absolutely. And then Paul, you just gave a talk, was it last week? Time's flying. Last week at the Executive War College, which kind of brings together healthcare and lab medicine. Any key takeaways or concepts when it comes to like involving those stakeholders in the interop conversation?
Yeah, well, first of all, I got a lot of interest. So it was only a half-hour Fortune General session, so it was a good size, 100,000, whatever people it is. There's a lot of people there. Yeah. A lot of head nodding, a lot of, oh yeah, that's true. The one thing I said I thought was fun is like, I think labs should participate at a minimum to make sure their data is represented well. EHRs are not doing a poor job of representing data. But some do it differently than the lab might expect. And one of the things I put on the screen, I showed my recent cholesterol test. And what's funny is my provider gave me two versions of it, I think by accident. They scanned the eFax, back to faxes, people. They scanned my text image result received from the lab company at the same time that came in as discrete data into my my EHR tethered patient portal. And like, just understand, your some of your data is being represented as this ridiculous fax, which has a whole bunch of words on it with only one number that mattered to me. Well, three numbers: the top, the LDL, the HDL, and then this other one had the three just with a chart. I want the chart. I want to see that it used to be better and now it's worse. And this thing just gave me a whole page of data, not OCR, not in some sort of, not discrete data. It's in there, but it's hard to find. And I was like, this is how your data is being accidentally represented. If you participate directly, and then we have personal health records also interacting, they'll get it from you directly. You'll be seen as part of healthcare as opposed to a thing on the side, right? Be at the center and make sure that you have representation as opposed to being an intermediary that's replaceable. Make yourself less of a commodity.
Yeah, absolutely. It's funny because I was thinking about, because I saw your slides, that fact or that sheet, and it's like someone was writing on a typewriter all of these different letters and numbers, like that's what it looks like. And then to try to decipher that is just,
The best you had was like, at least the number was in bold. Like, so right. And the typewriter sense, that means rewind, hit it again, rewind, hit it again, rewind, hit it again. Now it's really dark.
Yeah.
That's cool. That's an amazing presentation today. I'm so proud of you. But, but you did see, if you saw my slide, you saw right next to it was the exact same result.
Yeah.
From the exact same patient portal, rendered the way I want to see it, and the way a clinician should want to see it too. It's like 170 to 230. How fast did that change occur? And is it spiky where it's likely to go back down the next test, or is this a trend? And unfortunately for me, it's a trend, but that's the end of my cheese as an entree consumption.
Okay. To wrap us up, what would you say, what's the call to action for everybody, like to improve this so that in the next 5 years, we see these better connections and more integrated Ps? If we had to summarize real quick, what's our call to action?
The only way we move data is for people to participate. And that sounds obvious. You're like, oh, of course, we're trying to get a network scale. There's a lot of time spent on the outside looking in, trying to say, when are you going to make it attractive for me to join, right? When are you going to make it that this makes sense for me? And I'll tell you, on the inside, those same people are looking, well, we're not going to spend our time dealing with this stuff until you come inside. Like, you don't move the ball by complaining from the outside that the other people are not helping your stuff. It grows from the inside. And the patient portal, same thing. Like, we started, CommonWell laid tracks for provider exchange that in 2016 we were incredibly proud of, and it was ridiculously low number compared to today, but we were incredibly proud of then. I wasn't there, but the board decided to move that to patient access. It didn't really move until we had PHRs or individual access service apps inside yelling about the lack of progress, and then forcing us to really pay attention. And I say forcing, we shouldn't have needed it, but we did. Like, we needed to be like, oh, yeah, this is important. Oh yeah, well, of course we said it was important. Now it actually is. We need to. So payers, if you want to figure it out, start exchanging now. Like, it's not going to fix itself on its own.
I have to echo that. I mean, just this week, this is not a fight, but what we've been advocating for years. And just this week, because we have a PHR who's been on the inside, who's been advocating alongside of us for a long time now, I have positive feedback from 2 vendors that participate in national exchange that they are going to start responding, hopefully this summer to patient access queries, hot off the presses. And I'm not going to, I don't think it's my place to say who they are. But we are seeing positive movement. Athena Health has openly stated that they are, as they onboard to TEFCA and as they update their, contracts with their clients to do so, it's an automatic yes, unless a provider organization has a specific reason not to, which is fantastic. And I think that, we need to see more leaders on the inside doing that. And in order to, I think, push that narrative, I think Paul's exactly right. You need to have an insider, inside the network, inside the framework's voice where you can advocate for that. And we'll continue to do that alongside of you there.
Absolutely. All right. Thank you, everyone, for joining us. Paul, thanks for joining Liz and I today. I'm sure you'll be back.
For sure.
Yes, absolutely. So in 2 weeks, we have another special guest. We have Dee Dee from the Sequoia Project, and we'll be talking about all things, data usability and whatnot. So we will see you next time, May 22nd at noon. Take care.
Thank you. Thank you.
Thanks all.
Bye.